Hello, Ron Broussard here. Today we're going to be talking about Chapter 4, Documentation. Okay, now some of the things we'll be discussing is going to be the functions of the pre-hospital care report, the collection of data in patient care reports, medical abbreviations, some of the legal issues that we face when dealing with documentation, and then some of the ways that we can document a patient narrative. All right, now with the functions of a pre-hospital or patient care report is going to be the continuity of medical care. Ultimately, guys, we are the first responders. We are part of the continuum of care, so we take patients to the hospital and for them to ultimately receive definitive care. Now, those providers at the hospital, the nurse, the physician, whoever it is that is getting that patient, they are not on the scene with us, and we're not going to be there the entire time to give them all the information about the call. And they can use our documentation for their own care for that patient. Now, there are some administrative uses with that, such as billing and insurance reimbursement. So patients do get billed for everything that happens within a call. They will itemize a a bill for that patient based off of what you've documented. And now on statistics, as far as information for future planning, I mean, that can be used for a number of things, like resources that need to be allotted into a certain area, say for a higher call volume or for equipment usage. Okay, now again, with functions of the PCR, it is a legal document. So not just for patients that are crime victims, but if there is any civil case that comes up or criminal case that comes up where they need to reference this, it can be used in court. So that's one of the reasons why it's very important to keep documentation as objective as possible and to really only document like what you see, what the patient tells you, and not documenting any, say, feelings that you may have towards a call, even if it's, maybe a sensitive topic for you. Now, can dive into education and research. So with that, you can pull a lot of information from our PCRs to, say, research studies. I know a couple studies that I did while I was going through college was on compression-only CPR versus, say, compression and ventilation type CPR. And with that, a lot of the research looked at pre-hospital care reports to see, okay, what was done prior to, and then ultimately seeing what the patient's outcome was. Now, it can also be used for continuous quality improvement in a sense to make the system better. Now, let's say you have, an issue where patients aren't receiving the highest standard of care, or say skills aren't being performed adequately. Say if it's a missed intubation and you have multiple missed intubations that have been documented, well, a manager can look at that and say, okay, we need to, say, maybe push some training into that area. Here's an example of a pre-hospital care report. Now, this will be a written one. With this written one, you can obviously see that there is, kind of limited space for documentation. Like, this is all you get for medications. And patients have, notepads worth of medications at times. So it is limited here, and this is kind of what the benefit is for electronic documentation. All right, here's a touchpad. Now, this makes things very easy for you as far as this digital documentation goes. Like, you can mark on, say, an avatar where certain wounds are, where an IV is located, where swelling is. And then not only that, but when you're having to maybe type out something like, say, patient medications, oftentimes too it'll be preloaded where you won't have to spell out a medication, because who wants to try to spell out hydrochlorothiazide? It's like, if you could start the word and it will finish it for you, it makes it a lot easier. Now, basic rules of your PCR is, if it wasn't written down, it wasn't done. And if it wasn't done, don't write it down. So if it wasn't done, don't write it down. We never want to falsify documentation. All right. And it can be very tempting to do so. Like with documenting vital signs. You need 2 sets. It would be very easy to fudge a second set of vital signs if you feel like, oh, well, the patient hasn't changed much in the 2 minutes since we picked them up, got a set of vitals, and we're dropping them off at the hospital, but it's required. Let me just write these in again. You really don't want to do that. And then, of course, if it wasn't written down, it wasn't done. And now that's important because if you did something and it wasn't documented, okay, there's no proof really that you did it. Now, with the Department of Transportation minimum data set, it is established by the DOT, and it has standardized information that allows meaningful comparison and analysis for the improvement of EMS care nationally. All right, so this minimum data set is the minimum amount of information that is required for every call. Now, patient information of the minimum data set, we're required to get a chief complaint, a level of responsiveness for the patient. So, think your AVPU, your orientation type questions. We need to get a full set of vital signs. This lists off a few of them, and then the patient demographics. Okay, we need the time the incident was reported, time EMS unit was notified, time of arrival at the patient, time unit left the scene, time unit arrived at destination, and time carrier was transferred. Now this may seem like a lot, but guys, this really does get used for quality improvement. One of the things that they look at too is when I worked on an ambulance for a while, and response times were very big. From when we were dispatched to a call to when we arrived on scene, and then ultimately at the patient side, you have ambulance companies that are contracted with cities to meet certain response times. Now, this is a way that they manage and ensure that it's like, are they meeting those response times based off of what we're putting in our PCRs? Now, if you guys have longer response times, that's going to let them know that's okay. Maybe we need to staff more ambulances so we have a better response time to meet the needs of the city or town that you work in. Okay, now you have different sections of the PCR, which is administrative information, patient demographics, vital signs, patient narrative, and treatment. Patient narrative we'll talk about a little bit later, but in a sense, you're kind of painting a picture of what's going on with the patient, with the scene, with what you're seeing. And I like to use SOAP, so subjective, objective, assessment, and then my plan for a patient narrative. It helps me kind of lay it out easier. In a sense, it kind of looked like, okay, it's I arrive on scene with a 55-year-old male complaining of chest pain. Patient has a history of 2 heart attacks, high cholesterol, high blood pressure. Assessment findings reveal, blood pressure 140/90, heart rate is 90. Respirations were at 16, full and effective. O2 stats were at 92% on room air. My plan is to put the patient on 2 liters per minute in nasal cannula. We're going to go ahead and give him 4 tablets of aspirin and assist him with the use of his, nitroglycerin, kind of something along those lines as far as my patient narrative. Now, notice that last part there does kind of tie into treatment. So in the treatment section, you can have a quick and easy list of like, okay, I've done this at this time, this dose, and this is the patient's response to it. So talking about oxygen administration, that would go in your treatment section. All right, so some of your pearls here is objective information is verifiable and measurable. So objective, what you are seeing, what you can measure, okay? So a blood pressure is an objective piece of information, okay? A temperature is objective. Now, subjective is based off of what the patient is telling you or an opinion. So pain is a subjective thing, even though technically we measure pain, right? Between a 1 and a 10, where's your pain at? Like between 1 and a 10, 10 being the worst pain ever. Well, a 10 for me and a 10 for somebody else could be 2 completely different things, right? So pain would be more subjective because it's what the patient's telling you. Now, another way you can tie this in is objective is going to be signs. So things you can see, where subjective is going to be symptoms, things that the patient tells you. Now, pertinent negatives. Pertinent negative signs and symptoms that might be expected but are not found. Now, this is important because I am thinking based off of certain complaints that I should see certain signs and symptoms. A good example, and you guys will learn as much as we go through this course, when we talk about the different diseases and the disease processes, all right, well, a lot of these things kind of go hand in hand together, like a patient with cardiac-related chest pain. A lot of times, something that we expect to see or an associated symptom with chest pain is shortness of breath, difficulty breathing. So if the patient does not have shortness of breath with their chest pain, I would document that as a pertinent negative. So, my patient has a, 9 out of 10 chest pain radiating to the left arm. Patient denies any shortness of breath. So that would be something that I would document. My patient has abdominal pain. Patient has periumbilical abdominal pain, radiates to the lower right quadrant. Patient denies any complaint of nausea or vomiting. Okay, so those would be things that I would document as pertinent negatives because it relates to their chief complaint. Now, using accurate and synchronous time clocks, this is important for one, using like appropriate times. Like if you were dispatched and the computer dispatched you at 1400, all right, but your watch is 10 minutes slow and you're typing in information and you're putting in a manual time based on your watch, well, those times aren't going to jive if it's way off either way. Either you're going to be documenting things and it was before the call was even dispatched, or you're documenting things and it makes it look all really late for when you were documenting that stuff. All right, and then always obtain at least 2 full sets of vital signs. All right, medical abbreviations. There are a lot. And unfortunately with this class, we really don't dive into them. Okay, the one thing I'll tell you about medical abbreviations is I'm still learning. I started as an EMT, progressed into being a combat medic, and now I'm a nurse with my BSN in the ER. And I'm still learning different abbreviations. I see them all the time. The physicians will put in the orders, and I see like an abbreviation. I'm like, oh my gosh, what the heck does that mean? But it's a constant process of learning. Okay, so just don't be overwhelmed by it. It can be very overwhelming when you're reading it, just like medical terminology when we get into chapter 7. But just slowly start to add things to it. And then if you ever see something that you don't understand, look it up. Okay, now with medical abbreviations, the one thing I'll say is make sure that it is an approved medical abbreviation that you're using. Okay, we use these acronyms in the class to help us remember certain things, but just because it's an acronym to help you remember, say, certain steps of an assessment, doesn't necessarily mean it's an approved abbreviation. Now, abbreviations can be great because it can definitely shorten up your documentation. It can save a lot of time, but it can also be very confusing. Now, here are some universally accepted abbreviations. All right. Now, like I said, I'm not going to go into them all, but you guys can see how it can help shorten things up a little bit. Okay, such as I have a 45 to the 7 years old, YO. Male is just an M. It used to be like the little symbol for male. So, 45 YOM, CO, which is complaint of, SOB or shortness of breath. You see how that can really shorten things up for you as far as what you're actually writing or typing out. So it can be beneficial because it can save you a lot of time. Now, I remember just a funny story when I was in my combat medic course. I thought it would be funny to document, in a bunch of medical abbreviations and then submit it. And then my instructor looked at it and gave it back to me. He's like, yep, go ahead and redo that in English next time. All right. Because ultimately, guys, it's a learning process, and it can also complicate things too. I know that kind of muddied the waters a lot for y'all. Now, here's an example. This is what I like. You see how long this passage is here. 48-year-old male is alert and oriented with a complaint of severe chest pain and trouble breathing. He took 2 nitro without relief today. He is prescribed Lasix twice daily. He has no known allergies. So take that. We could break it down with those medical abbreviations, okay, into something that's a lot shorter, like easier to digest. Now, some of the legal concerns, confidentiality. What you put in that PCR is private, okay, and it is protected by HIPAA. Now, we do not want to release or leave behind anything with patient identifiable information because we want to protect that patient's privacy. That's one of the reasons why we give you guys the handheld, the handwritten patient care reports for you guys to take on your write-outs, because we don't want anybody taking home any copies of patient care reports from their write-out, because technically that shouldn't be coming back with you. Okay, so we never want to have anything that can identify our patient. So no patient identifiers such as like name and date of birth. Okay, distribution. Now, certain people have access to PCRs, and one of those is quality improvement and medical oversight. Okay, so the people who actually review our patient care reports for continuous quality improvement, they're going to have access to that information. Okay, billing, they'll have access to that information. If it's part of an investigation for a crime, law enforcement will have access to it. Also, if you guys ever get sued, hopefully that never happens, but if it gets subpoenaed in court, okay, at that point it'll be part of that trial, okay, and it'll be distributed appropriately. Now, refusal of treatment. So this is where documentation is very important, because if a patient refuses care, and they want to go, say, against medical advice, we need to make sure we document a thorough neuro assessment, so their mental assessment. We want to make sure that that patient is alert and oriented and mentally competent to understand the risks. Okay, now if I let the patient AMA, but I don't have documented anywhere that I did a mental assessment and that patient deteriorates way later, okay, I have nothing to prove that that patient was capable of refusing care in the first place, and I can get in a lot of trouble then. So we want to make sure we document thoroughly. Now, some of you guys are thinking, well, if they refuse care, refuse anything, it's like, well, I mean, at that point, you're technically just asking them questions, right? Every call you go on is going to have a PCR assigned to it. Okay? Even if the PCR is you arrive with your ambulance and the fire department cancels you as you approach and you never make contact with the patient, they simply document it's like arrived on scene, canceled by fire, no patient contact made. It could be very short and simple like that. Now, if you're talking to somebody and they're like, no, I don't want to go to the hospital, well, you can engage them in conversation to develop their mental state, to then document that in your patient care report and then have them sign an AMA. We always want to persuade the patient to accept care. So, we're going to let them know of the risks up to and including death of their refusal of care. And then we're going to document what we told them. Okay, so if you told them that there is a possibility that this could be happening and that you could possibly die if you don't get care, we're going to make sure we document that we told the patient those things. All right, so document the following information. If the patient refused any or all assessment and the treatment offered, the patient's mental status in making the decision, and then have the patient and witness sign the form, the AMA form. All right, so here's an example of one. Now, depending on where you work, they look differently. All right, but this is an example of that. I know the ones we have in the hospital are like really long, where we need to document that we've identified the patient using a couple different methods, and then the mental assessment check is all in the AMA form. So just be familiar with whatever agency you work for in their AMA or patient refusal documentation. Okay, now falsification of PCRs. Now, with falsification, it could be a mistake, or it could be falsification where you're writing something down that didn't actually happen. Ultimately, it compromises patient care. Now, this can lead to loss of license, okay, loss of certification, and even criminal charges. Okay, like if you're documenting something and say it protects an individual or a patient, from a legal standing, all right, and you're falsifying to protect them, okay, you could possibly be held negligent or liable and charged with obstruction. Okay, now mistakes or omissions must be corrected, okay, and fixed as soon as possible. Now, here's an example of a handwritten one, and then, making the correction. Now, ultimately, with a computerized documentation, it allows us, if we make a mistake, if I type down right, and I mean left, I can backspace and then correct it. Now, if I type it all out and I submit it, at that point, I need to do an amendment to that PCR and then just submit the corrected information. Now, for handwritten, it's as simple as drawing a single line through it and then initialing. Now, with the single line through it, I say this every class, and we get PCRs back from patients or from students at the end on their clinicals, and you all will still scribble it out. Like, we don't want to be, you guys don't want to show us what you actually wrote down. Guys, just quick and easy, save some ink, single line through it, and initial. All right, now transfer of care. So transfer of care used when it is not possible to complete the full PCR and obtain signatures before leaving the facility. A special type of transfer of care form may be used. A full PCR must still be submitted as soon as possible. Now, there are going to be times where you get busy. Okay, there are going to be times where you get busy or the hospital is slammed and you're getting pulled off scene. These things happen. In a sense, what happens is you kind of submit an incomplete form, and then you go back when you have time and then finish it and sign it and submit it. All right. Just know that you want to do that sooner rather than later. I've worked with people who've, pushed off documentation until the end of their day, and they must have a lot better memory than I do, because I'm like, I forget things that happened a couple hours prior, let alone like 8 hours prior. So just make sure you're going back and completing that form as soon as you possibly can. All right, MCIs are another special case where, it's like we're not necessarily worried about, a full, 2 sets of vitals and everything, especially if it's moving quick and the patient's getting moved on. With triage, we are getting pertinent information down. We'll talk about actually triaging patients in a later chapter. I believe it's chapter 44, 45. We talk about triage, but in a sense, it's a way for us to quickly communicate pertinent information and get our patients to get care. All right, in triage, we do the greatest good for the greatest number of people. Now, with special reporting and us as EMTs being mandated reporters, we must report all aspects of abuse. All right, we must report all aspects of abuse. Now, let's say you have a patient that, is an 8-year-old that has injuries that you suspect as abuse. Okay, you are not documenting on the patient care report that, the patient was abused by the father because of this. What you're going to say is the patient has bruising and, lacerations to the right upper arm. Patient states, and then in quotes, what happened. All right. And then, if any other family member, like the dad or the mom, tells you something, it's going to be all in quotes what they tell you happens, but you document everything that you see objectively. All right. You don't say abuse in your documentation. You say it's like a patient has, small burn marks, that are about 1/2 inch in diameter on the distal aspect of their right arm. You're not going to document that, I believe the patient had cigarettes put out on their right arm. No, because everything has to be what you see. Unless you actually witness that happen, everything has to be objective. Now, when you get to the receiving facility, or if, say, there's an issue where they're not letting you transport the patient and the patient needs care, okay, you can engage and use law enforcement. And then you could tell them what's going on, and then in your report, they're going to be collecting information like that. But for your PCRs, objective, and everything that gets told to you gets put in quotes. All right. Now, other reports: infectious disease exposure, injuries to EMS providers, and situations requiring additional documentation or notification of other agencies. Okay, such as crime scenes. All right. Depending on where you work, drug use. Okay. Those are going to be cases where you need additional documentation. Now, some of our alternative documentation methods. So this is where we're getting into kind of your patient narrative aspects. So SOAP, chart, and cheetah. Now, these are just different ways to help you set up or frame your narrative. Now, in the military, we use a SF600, and it is literally just a blank piece of paper with lines on it that we document a patient narrative on. So I find that SOAP helps me a lot kind of frame up that blank piece of paper, because it's not at all like those PCRs that you guys saw earlier in the chapter, where it had like sections for everything. Okay, so with SOAP, we do subjective, objective, assessment, and plan. So I start off with my subjective information, kind of what the patient is telling me that's going on in their chief complaint. So, a 45-year-old male with a complaint of lower right quadrant abdominal pain. Okay, patient states that the pain started yesterday and is 9 out of 10 and feels like somebody's stabbing him with a knife. Okay, so that's all stuff that the patient's telling me. Patient has a history of, gallstones, diverticulitis, and states that he's had diarrhea for the last week. All right, now objective information. Okay, now I'm going to start the next paragraph, and it's going to be kind of what I am seeing. All right, so I'll start off like, patient skin signs are, cool, pale, and diaphoretic. Okay, vital signs are objective in nature. So blood pressure is 104/62, heart rate's 120, respirations were at 22, all right, and oxygen was at 96% on room air. All right, so that's all measurable, objective stuff. So next thing is going to be assessment. Now, assessment, remember, we don't necessarily document, or we're not diagnosing patients, but with the assessment, we put down our field impression of the patient. Okay, so what we think is going on. Therefore, your plan correlates to that. So let me kind of tie this into a good treatment plan. Whereas your assessment finding for a patient, say, with chest pain, okay, well, patient suffering from cardiac-related chest pain, that's my assessment. So my plan is going to be, it's like we're going to administer, 324 milligrams of aspirin. Okay, we're going to assist the patient with 0.4 milligrams of their nitroglycerin sublingually, and we're going to apply nasal cannula at 2 liters per minute to the patient and transport them to Loma Linda or XYZ hospital for treatment. All right, so that's kind of how that would look. All right, now, so B kind of ties in intervention and evaluation. So it kind of extended out the plan a little bit. Now, intervention, that's going to be what we're doing for the patient. Okay, and then evaluation is kind of like our disposition, or where we're ultimately going to be taking them. The SOAP stays the same. Chart is another one. So chief complaint, history, so that includes samples, so signs and symptoms, allergies, medications, past partner medical history, last oral intake, and events leading up to. Okay, now signs, allergies, medications, past medical history, that could all, if we just use SOAP, go under our subjective narrative, right? Our assessment, treatment, and then transport, where we're transferring the patient to. All right, so that concludes this class. All right, what we talked about is PCRs and the function that they serve, good documentation, should be accurate, concise, complete, and clear. Okay. Exercise caution in special reporting situations. Remember, just document what you see. Objective. If somebody tells you something and you want to put that in the PCR, put it in quotes and actually, put down who told you that information. All right. It will protect you. Okay. Never falsify a report and correct mistakes as soon as possible. All right. Now, this was kind of something that I popped up here. So I would review this. Like if you got to take a quick screenshot of these, my assignment for you guys is to look up these medical abbreviations on here. Take time, get familiar with the ones that are on this slide because you may see them again. Okay. That's my assignment for you. Hope you guys have a good day.